welcome to this JACC podcast. I'm Theresa McDonagh. I'm a heart failure cardiologist from King's College Hospital in London and an associate editor from JACC. And it's my pleasure today to be introducing Dr. Akshay Desai from the Brigham and Women's, who's going to talk about a simultaneous publication that he and his group have got at the American Heart Association meeting.
Well, thanks very much, Theresa. It's a pleasure to be here. I'm very excited to share with you some of the work that Henry Liu from our group will be presenting at the American Heart Association meeting.
Great. And obviously, there's a simultaneous publication in JACC. And it's a very interesting study, a meta-analysis of 4 trials in HFpEF, looking at blood pressure and pulse pressure, and I suppose telling us something about their ideal range in patients with HFpEF. So, Akshay, do you want to tell us the main highlights of your paper?
Sure. So I think, as you highlighted, Theresa, I think there's one of the key targets for therapy in HFpEF for many years has been, even prior to the availability of targeted medical therapy, has been blood pressure, because we know that a large proportion of these patients have antecedent hypertension. And the question of how aggressively to manage blood pressure in this population has been an open one. We don't have a lot of guidelines about the specific blood pressure targets. And so what we tried to do in this pooled analysis of 4 different HFpEF trials that comprise about 16,000 patients with HFpEF was to examine the relationship between baseline systolic blood pressure and baseline pulse pressure and the clinical outcome composite of death or cardiovascular death or heart failure hospitalization to assess whether what the relationship is of blood pressure and pulse pressure to risk, and then to identify whether there is a low risk window within that spectrum that might be informative for clinicians in practice. And essentially what we found is that there is a relationship between blood pressure and risk that appears to be U-shaped, and this has been identified before. Very low blood pressure and very high blood pressure, both associated with risk, with the nadir of risks somewhere between 120 and 130 millimeters of mercury in this large pooled HFpEF data set. And that for pulse pressure, which is an important contributor or component of blood pressure, which reflects the difference between the systolic and diastolic pressure, probably as a marker of arterial stiffening in this population, but also correlated with stroke volume. And what we found is that pulse pressure between 50 and 60 millimeters of mercury reflected the nadir of risk in a similar U-shaped relationship. And then I think the interesting piece was that if you looked at the cross of blood pressure, systolic blood pressure and pulse pressure, that the patients with high pulse pressure and high systolic blood pressure were at highest risk. So I think that there is some information that pulse pressure does add prognostic information to systolic blood pressure.
Great. It's a big data set and very nice work. I suppose for a clinician looking at it, they'll say, well, there are 4 different trials here in HFpEF, and some of them, of course, used agents which lower blood pressure considerably, and others do not. I'm thinking of, obviously, iPreserve and Paragon, so with ARB and ARNI, agents known to lower blood pressure a lot. Then we had Top Cat Americas with spironolactone, a good drug for resistant hypertension, and then Deliver with the SGLT2, which of course has lesser effects on blood pressure. Did you find a consistent effect in terms of lack of heterogeneity across the trial with these results?
Yes, so there does appear to be a consistent effect across the trials. You're absolutely right, of course, that the intervention certainly impact blood pressure. But one reason for that may be that the focus here was really on the baseline blood pressure prior to the often at the time of randomization in the trials. So this sort of is an effect before the effect of treatment is really evaluated. So I think properly, this is really an analysis of baseline blood pressure or baseline pulse pressure and its relation to incident cardiovascular outcomes. And the other question one could ask is, what about the treated blood pressure
Yeah.
in the trials. But I think nonetheless, it does sort of affirm some of the previous analysis we had about this U-shaped relationship with risk. The nature of that relationship, I think we still need to understand a little better. I think it makes sense, certainly, that severe hypertension is undesirable. And the nadir of 120 to 130 correlates with our current treatment guidelines about blood pressure in general. I think this low end of heightened risk with hypotension is something that clinically we've all observed in practice, that some patients, if you get too low, the renal function gets worse, and perhaps the patients don't do well. And maybe also in that low end, we're confounding more patients who have overlaps with other syndromes than hypertensive heart disease, which is the bulk of our populations with HFpEF. But yeah.
So I think at least for clinicians, we're seeing a consistent message with what we're doing with patients with hypertension, treating to less than 130. Would you think 130 over 80, obviously from the SPRINT trial? Do you think we should really follow similar targets in terms of the actual blood pressure in patients with HFpEF based on your data?
I think that is right. I'll be candid that I don't think that this is not a prospective trial of targeted blood pressure therapy. This is an observational analysis of the relationship between continuous blood pressure and risk. But it seems consistent with the guidance that you outline, that this is the target blood pressure, and probably counsels clinicians that being overly aggressive with blood pressure may not be desirable in this population. But also treating to guideline recommended targets is probably important for modulating risk in this population. And then I think also the incremental guidance about about pulse pressure may be important, simply in risk stratifying the population, because I think those patients with very narrow or very high pulse pressure may be at slightly higher risk, and I think we see that in this analysis as well. We don't yet have great therapies that target pulse pressure, but we know that agents that lower blood pressure and lower pulse pressure, particularly renin-angiotensin system inhibitors, are drugs that seem to have the most impact in hypertensive populations. And so maybe that affirms some of our evolving clinical evidence about the way in which we select antihypertensive therapy in this population as well.
So, very nice paper, and congratulations, and good luck to your fellow with the presentation.
Thanks very much. Thanks very much. And thanks for the interest from JACC.
Thank you.